Good morning. My name is Quirino Lai. I work in Rome, Sapienza University of Rome. The topic of my presentation is to explore which is the best way for selecting patients with hepatocellular cancer waiting for liver transplantation in Latin America. I'd like to start with the first successful liver transplantation done in the world by Professor Starzl. And the first transplant was performed in a child with HCC. And in this first transplant, we can see both the sides of the coin when we do a transplantation for hepatocellular cancer. On one side, the success. It was the first successful procedure with more than 1 year of survival after transplantation. And on the other side, we have the risk of recurrence. And in fact, the patient died due to recurrence after 13 months from transplantation. And we know that at the beginning, we are talking about 70s, 80s, several centers decided to stop the activity due to the higher risk of recurrence. However, in 1996, Professor Mazzaferro from Milan had the brilliant idea to create the Milan criteria. The Milan criteria have been a huge success worldwide because they are very easy to be used and they are only based on morphological aspects, namely the dimension and the number of the lesions. And the great success of the Milan criteria is also connected to the fact that when we look at radiological Milan criteria, we know that a certain percentage of cases at the pathology are out of the Milan criteria. So it means that the Milan criteria are able to capture also slightly enlarged cases. When we increase our criteria, San Francisco as an example, we know that a certain percentage of cases will be out of San Francisco at pathology. So it means that the risk of recurrence will be increased. And this is the reason why Mazzaferro proposed the metro ticket paradigm, another brilliant idea. In fact, we know that when we use only morphology and we move from Milan to other places, so other criteria, the longer is the trip, so the higher is the enlargement of the dimensions, the higher is the cost of the ticket, so the higher is the risk of the recurrence. This is a very successful image of how it works when we enlarge our morphological aspects. However, on the other side, we know that the Milan criteria only capture the top of the iceberg and that several patients with hepatocellular cancer can't be transplanted due to the fact that they are out of the conventional criteria of transplantability. And we also know that during the waiting time period, our patient is not a stable patient with a clear evolution. We know that we do several local regional treatments, and we know that lesions can be destroyed, and then new lesions should be detected, and the alpha-fetoprotein starts going up and then starts going down. So we know that if we look only at a frame, a single image of a picture, probably we are not able to completely capture the complexity of the situation. And here, Mazzaferro, another time, trying to square in the circle, we know is an impossible mathematical problem. And in fact, it's really, really complex to well capture the real risk of a patient waiting for liver transplantation with hepatocellular cancer. We are not talking about the cases transplanted in the 90s. We are talking about a patient with several different local regional strategies to be used before transplantation and several aspects to be considered. And in fact, we are not looking only at the static image. the blue water lilies of Monet. But we are looking at a great wave. We are looking at a modification of a dynamic process. And when we enlarge our criteria, we know several centers proposed a larger criteria. We are able to increase the number of transplantation up to 60% of the cases. So a great enlargement, the ability to go down of the level of the water, looking iceberg. And the other side, which is the risk of the higher mortality or recurrence. Actually, they are acceptable because enlarging the criteria, we are able to obtain good survivors, good results. Why this? Because we are not only talking about the enlargement of the morphology. It's not only push the criteria with the intent to increase the number of transplantable cases, but is a concept of reclassification of our patients, only adding something new. And this something new is actually the biology of the tumor. When we look at the results in terms of recurrence, comparing the Milan criteria with the new larger criteria proposed in this meta-analysis, you can see that the survivors are similar. So it means that if we enlarge our criteria, actually, the metro ticket paradigm is not completely real in the clinical practice. So what does it mean? That we are trying to move from the metro to the last frontier using the introduction of new parameters, so biology. We know that when we talk about some types of cancer, like colorectal cancer, breast cancer, nowadays we need to know several genetical aspects, RAS, BRAF, BRCA1 and 2 for the breast cancer. We know that we decide to do chemo, which type of chemo, and also surgery according to these aspects. Unfortunately, for HCC, we are not able nowadays to do that. But we know that we have some surrogates of biology. The surrogates are alpha-fetoprotein, other markers like the PIVCA, that is more commonly used in Asia, but that should be considered also in Western countries. The inflammatory markers, and also the way in which the tumor responds after local regional therapies, so the radiological progression of the tumor. Looking in detail, obviously alpha-fetoprotein looks to be the most important among the different biological parameters integrated in the selection criteria. Here you can see the alpha-fetoprotein French model. It is a paper, here is a paper from Professor Duveau, proposed 10 years ago. And that is very well demonstrated to be an excellent criterion for selecting patients with HCC. And in fact, it is used commonly in France for the allocation process. And also the alpha-fetoprotein French model has been externally validated in several countries, also in South American ones. The train score is another score in which alpha-fetoprotein have been integrated into several other parameters. Actually, in this case, we are not looking only at the alpha-fetoprotein, but also at the dynamics of alpha-fetoprotein. So how the alpha-fetoprotein changes during the time of the waiting period. And lastly, another time, Mazzaferro, the Metro Ticket 2.0 score, in which a combination of alpha-fetoprotein and the sum of number and diameter of the lesions can be used for identify the risk of HCC-related death after liver transplantation. What about the PIVCA? The PIVCA is commonly used in Asian countries. Here you can see a meta-analysis with some papers coming from Japan, in which the integration of PIVCA into selection criteria showed a great ability of identifying patients at high risk for recurrence after liver transplantation. But we are waiting for papers coming from Western countries exploring this parameter also in the setting of America and Europe and so on. What about the inflammatory markers? Another important issue to be explored. They are very easy to be calculated because they are ratios between neutrophil lymphocytes, platelet lymphocytes, and we know that typically they increase when we have an advanced cancer, mainly because the platelets increase or the neutrophils increase in the presence of a tumor. And some papers have been published on the potential role of these markers for selecting patients with a risk of recurrence after liver transplantation. And the results are contradictory. Some papers demonstrated the ability of the neutrophil to lymphocyte ratio, mainly in the setting of waiting time period for the intent to identify patients with a risk of dropout due to HCC. But in very well selected cases, the risk of recurrence after liver transplantation has not been clearly identified. So in other articles, so we need to further explore these parameters in the setting of liver transplantation. What about the radiological response? Here is there are several papers very well demonstrated that the response after local regional therapies is a very good way for observing a surrogate of the biological aggressiveness of the tumor. And in this paper coming from a large European consortium, you can see that the combination of alpha-fetoprotein and the way in which the tumor responds after local regional therapies better discriminates the patients respect to the Milan criteria. So also the patients within the Milan criteria, but with the poor response after local regional therapies and an increase of the alpha-fetoprotein present very poor results. And this is the case, I said before, is not an enlargement, is a recalibration, is a reclassification of our patients. There are some patients within the Milan criteria with a risk of recurrence, and integrating the biological aspects should be useful for better discriminating also these patients, also the patients within the Milan criteria. Lastly, the artificial intelligence. We know that when we construct models, we try to find the easier way for using these models. But sometimes the reality and our attempts to capture the reality is not easy. So we need to construct complex models, and artificial intelligence can help us from this point of view. And here you can see some recent papers coming from Canada and South Korea, focused on the development of some new criteria able to identify patients at high risk for recurrence after liver transplantation. And these models have been created using the deep learning, so the artificial intelligence technology. And so in conclusion, we can say that probably Milan criteria are no more the best selection criteria because they are too restrictive. And in some cases, we know that we have recurrences also using the Milan criteria. So we need to modify our paradigm. We need to reclassify our patients also using the biology, alpha-fetoprotein, radiological response, probably inflammatory markers, probably the use of new biological markers like the PIVCA. And so the use of new larger composite criteria comprehending also tumor biology surrogates like the alpha-fetofranc or the Metroticket 2.0 should be very useful for implementing our ability to well discriminate our patients waiting for liver transplantation. And looking at the future, probably the development of a molecular and genetical new way of classifying our patients, and also the use of model constructed using artificial intelligence should be the next feature for further improving our ability from this point of view. Thank you very much for your kind attention.